Greetings and welcome to the Quality Insights podcast for healthcare professionals. My name is Jill Fleur and I am an Assistant Project Coordinator at Quality Insights and participate on a team of staff dedicated to promoting and providing CME eligible opioid education sessions across the Commonwealth of Pennsylvania through our partnership with the Pennsylvania Department of Health. We have a great topic and conversation lined up today, focusing on Pennsylvania's opioid crisis, specifically related to the dental community and Project Home. With that, I'd like to introduce two guests who are here with me today. First, I'd like to welcome my colleague, Jason Sett, who serves at Quality Insights as a practice transformation specialist. In his role as a PTS, he's currently engaged in two different quality improvement initiatives in partnership with the Pennsylvania Department of Health to promote evidence-based prescribing and to help providers increase their quality of care through diabetes, hypertension, and cholesterol management. I'd also like to give a warm welcome to one of our clinician champions, Dr. Janine Burkhardt. Dr. Janine Burkhardt earned her Doctor of Dental Medicine from Temple University Kornberg School of Dentistry and a Master's in Public Health with dental emphasis through A.T. Still University. She is the Dental Director at Project Home in Philadelphia and current President of the Philadelphia County Dental Society. Dr. Burkhardt has achieved fellowship with the Academy of General Dentistry and completed the National Oral Health Leadership Institute. She's an active member of the Pennsylvania Academy of General Dentistry and Pennsylvania Dental Association and the National Network for Oral Health Access. Jason, I'll hand it over to you to get this conversation started.
All right, thank you, Jill. And it's great to have you here with us, Dr. Burkhardt. It's always great to learn from a practicing professional rather than reading articles online or in books. So I'm really happy that you could be here with us. Just as a little background to the conversation, the issue of opioid use disorder and overdose deaths has really been a major issue in Pennsylvania over the past decade. In Pennsylvania, really had an issue being the third highest overdose deaths in the nation in 2020. And overdose in PA peaked in 2017 at about 5,400 deaths for Pennsylvania. And then with the implementation of the PDMP, we saw about a 20% decline, which was a really encouraging sign for 2018 and 2019. So that dropped us to just under 4,500 overdose deaths per year. Unfortunately, over the last couple of years, it's been back on the rise, and that has reached a total of 5,301 overdose deaths in 2021. So we're getting back to close to where it was pre-PDMP implementation here, and that's the Prescription Drug Monitoring Program. Although these numbers of opioid prescriptions by dentists are down by about 30% from 2017 to 2020, there were still over 180,000 patients that received opioids from dentists in Pennsylvania in 2020. So it's important to note here as well that dental providers are often the initial source of opioid exposure for adolescents and young adults. And that really increases the likelihood of opioid use disorder later in life. So Dr. Burkhardt, could you please tell us a little about yourself and some of the work that you're doing?
Sure. Thanks, Jason. I'm Janine Burkhardt. I'm a general dentist that practices in Philadelphia. I originally grew up in the Scranton, Pennsylvania area. And like Jill said, I went to dental school at Temple, and then I completed a master's in public health with a dental emphasis at A.T. Still University.
What had pulled you into this type of work?
Sure. So Project Home, it has a mission to end and prevent chronic street homelessness. So we do this through a variety of services in the organization. The HOME, they all stand for different things. So H is for housing, O is opportunities for employment, M is medical services, which has since expanded to include a more broad range of health services, including dental, and then E is for education. So we really recognize how these services are interrelated. And it's really hard to get back on your feet if you tackle just one of these at a time. So if you kind of imagine trying to get a job when you're not smiling because of missing teeth, or maybe you just got a new job to try and pay your rent, but now you can't focus because you're having so much tooth pain. So we try and provide all of those services at once for the residents. So the population that we serve, there are patients that are experiencing homelessness. We also serve kind of the surrounding neighborhood of our main health center, which is the second poorest zip code in Philadelphia. So even though all of our patients aren't homeless or experiencing homelessness, they're still at risk of homelessness. So that's kind of the population that we work with. And for what drew me there, I always really enjoyed serving others. And I did a lot of volunteer work even through college. But throughout dental school, at Temple in Philly, I really saw that there's huge oral health disparities right here in Philadelphia. Um, I've done some international volunteer trips, but I realized that there's just such a big need here locally. And the opportunity for Project Home kind of popped up, and I realized the impact that I could make by helping to start their dental department when it opened. And it's really providing a safety net for patients that might otherwise have to go without care because the population we serve, a lot, they're either uninsured or they might have Medicaid and they have difficulty finding providers that will see them and be able to get care affordably.
Yeah, that's great. I'm sure that's an area that you could make a great impact in on increasing the health or the dental health of the people in general and improving their entire quality of life there. So it's really great that you were able to find something like that with your profession. So when you are treating these patients, I'm sure you see all kinds of issues, all kinds of dental problems, and all kinds of different pain. Being that this is part of the prescription drug monitoring program presentation, do you have specific guidelines that you follow for treatment of pain in your patients? Are they just general guidelines for pain management, or are there specific guidelines for dental that you generally stick to?
Yeah, so as a general practice, I usually work off of Pennsylvania guidelines on the use of opioids in the dental practice. Sometimes I might vary a little bit, but the guidelines, they're pretty basic and they're a way to advise us on how to prescribe for patients to manage their pain. Um, Under the guidelines, unless there's a contraindication, you'd first manage the patient's pain with an NSAID, and that's after you get a diagnosis for the patient and what's causing their pain. If the pain is moderate, then I'll add on acetaminophen afterwards because acetaminophen really has a synergistic effect with NSAID medications. Um, and really, that studies have found that the NSAID with acetaminophen combined can really have the same efficacy as a low dose opioid. So that's kind of my first line for how I manage patients' pain. If there's a patient where I think that they're really going to have severe pain after the procedure, I might even dose an NSAID before I do the treatment. It's a little less common for me, but I certainly do it if I think it's going to be, really challenging surgery where the patient might be uncomfortable afterwards. And then sometimes too, I'll even consider not prescribing, but injecting afterwards a long-acting local anesthetic, just because that can help carry the patient over until they can get their medication and it can kick in. Um, so I very rarely prescribe opioids. If I do, I follow these same guidelines where first you obviously have to check the PDMP, and then you assess the patient's risk for opioid misuse. And if you do prescribe, then you want to pick the lowest potency and the duration for the medication. So that way you can manage the patient's pain while also minimizing the risk for the opioid misuse. So it's pretty much what I stick to. And like I said, there's maybe some small variations along the way, but overall it's general guidance that I think is pretty easy to follow.
Okay, great. So I'm also sure that in the course of your work, you see a lot of patients that have some warning signs for opioid use disorder. What type of red flags do you usually see in patients, and how do you address these red flags with your patients?
Yeah, so we definitely see the patients like you're describing. I think for a patient that's coming into my practice, if they have a warning sign of opioid use disorder, I first want to recognize that they're in my chair because they need some kind of assistance. They didn't just come for fun. So I want to work first to determine if the patient's actually in pain. If they're having pain or acute dental pain, my goal is to treat them so that I can help lessen their desire to actually want to take pain medication. But I also like to have a conversation with them. Sometimes they might feel like you're working against them by not prescribing an opioid, but I try and help them recognize I'm really there to help them and do what's in their best interest. So depending upon how that conversation goes, sometimes I might end up connecting them with our medical team for a referral if it seems that they could benefit from substance use treatment. And as far as specific warning signs or red flags that maybe they have substance use disorder, um, the first one I think you might see is that the patients could be resistant or even deny like a diagnostic evaluation where they don't really want you examining all of their teeth. Or they might get irritable when I start to ask more questions about their pain symptoms. And I'm asking those to get a diagnosis, but it's kind of a sign for me maybe that they're focused on something else. They also sometimes could have maybe a little bit disruptive behavior in the clinic. But I do want to caution on these red flags because sometimes people are just really in so much pain that they're not their normal selves and they're having a really bad day, and that might come out in their actions. Um, but I think there's some other red flags where they might make me think that somebody is definitely more at risk of potentially misusing their medications. Some people will come in and they demand a specific drug by name and a specific dose, and they might even tell me just one pill, or two pills. Um, so that I think is a pretty big red flag. They might also show more concern for the drug itself than the actual dental condition. So kind of related to what I was saying, where they're not really telling me as much about their tooth, but more about the medication that they want. Um, we see patients sometimes that will claim that they are allergic kind of to every drug under the sun that isn't an opioid. So then I have to dig a little bit deeper to find out if they're true allergies or if that's just a way to try and get me to prescribe something that they like. Um, Other times, maybe we see patients that they might self-medicate inappropriately. They might say that they've been taking some medication from a friend. So when they tell me what they're taking, I can kind of ask, well, where did you get that from? Or were you being treated previously for this? Other times, maybe they'll take a drug that's not even really meant to treat pain. So maybe something like a sleep aid. Um, and I certainly always would check the PDMP for these patients. So with that, I might notice that they've been seen by multiple providers and gotten prescriptions at a number of different places. Um, so I guess for one specific example of a red flag patient that comes to mind, I have a patient that has, usually pretty mild dental pain, but when she comes in, she's requesting or even really demanding some very specific opioid prescriptions. So then if I don't give them to her, she may threaten to sue me. She's going to report me, or she's going to go to the ER. Um, and I think while these visits are really difficult and it might feel easiest to just give in and write a prescription, I think it's really best for the patient that I don't do that. Um, so I try and recognize first that that anger isn't really directed towards me. Um, Oftentimes for patients like this, there might be a long history of trauma, and an opioid prescription might seem to them like something that can numb their pain that's going on in their life. Um, and if they have that history of trauma, they certainly might not trust many people, me included, especially if they've just met me. Um, so for these patients, I think the best thing I can do is really to be firm in my boundaries instead of set them up for more danger and possible addiction. Um, Visits like that could be really tough, but I just have to continue to remind myself that I'm there to do what's really best for the patient's well-being, even if they don't recognize it. And I certainly try and help them recognize it, but it's a difficult conversation for sure.
Yeah, you really have to feel for some of these people that are suffering through the opioid addictions, and they can get pretty creative and convincing in their arguments. So it's good that you stay with your guidelines and try to do what's best for the patient, whether they realize that or not. Also, I wanted to ask you about COVID-19. COVID pandemic has really affected healthcare across the board with everybody. I know with primary care, people not coming in for their routine exams and treatment of chronic conditions. Did you see a big change in dental care with the impact of COVID-19?
Sure. So COVID-19, I think it had a really huge impact on the dental profession. Most dental procedures, even the ones that seem like the smallest procedures, they can generate aerosols. So at the very beginning of the pandemic, before we really knew enough about the virus, um, most dental facilities in Pennsylvania were actually shut down. So at that point, patients could really only access care by telehealth. And then dentists, they advocated, on the importance of oral health and to keep offices open. And then dentists also implemented a lot of extra precautions. So patient screenings, maybe some extra PPE, and even upgrading the filtration systems in the office. But even when offices were open, I think many dentists still tried to triage emergencies through telehealth. So that way, the patients that were coming in the office were patients that we knew really had to be there. Um, so that limited COVID risk, but also because there was limited appointment availability for all the patients that now needed to be scheduled. So I think really looking 2 years into the pandemic now, a lot of dental offices, we've certainly adapted and we're persevering and we're open kind of as usual business. The staff, they're protected with their PPE, but for the patients who are getting their treatment done without a mask on, they're taken care of with the filtration systems that are in place. I think it's important that we really keep working in the dental offices because dental care is really an essential part of oral health. And what we're seeing now is even increased dental disease because many patients, they're so overdue from their appointments, partially from when dental offices were closed down, but also because, some patients, even when the offices were open, they were still worried to go out and get their treatment done. And when they were at home, they might not have practiced the best dental hygiene. So we're just seeing so much need for treatment at this time. And then another complicating factor of that, nationwide, there's really a dental assistant shortage right now. So that's really affected our workforce, and it can make it tricky to keep schedules open for as much patient volume as dentists might be used to seeing. So that's made things a little bit complicated. And I think with the unavailability of, patient visits in person, there was certainly an increase in prescribing because there's only so many things you can do when you're on a dental telehealth visit to advise a patient to help their dental concerns. So often a prescription might be the only answer to hold them over until they can get into the office. And I think the telehealth visits, they certainly have a place in education, and they're really helpful in triaging to sort of assess what's going on. But when there is dental pain, the options to treat it usually are that definitive treatment or a prescription, but ultimately that prescription is just going to delay the need for definitive treatment a little bit longer. So in opioid prescribing, obviously it's something we like to avoid, but I think that dentists might have felt a little bit more at risk of prescribing because there were only so many tools that they had in their tool belt when you're doing something with telehealth. And if you're prescribing NSAIDs and acetaminophen and the patient's saying that they're continuing to have pain, they might be thinking, well, what else am I going to do if I can't get you in the office? So it's great that the offices are open now. But the telehealth, I think, can really just help triage who's in the most pain and who do we really need to get in the office to see, even if we can't have a full schedule open because of the staffing shortages.
Yeah, I realize that in-person evaluation for dental pain and opioid prescriptions especially is much preferred, but that's a tough situation that you're in there. So I don't know, were there any specific guidelines that you followed as far as telehealth? Did they have to, was there something that cued you that it was real rather than someone trying to just seek out more opioids? Was there anything that you noticed in that process with telehealth?
Yeah, so I didn't really have set guidelines, but I think we really, at our practice, we made space for patients that were having a lot of pain to come in for the appointment. The initial shutdown was really 2 weeks. I think it was 2 weeks. And then after that, we weren't open for routine care, but we were certainly open for emergencies. So if we held somebody over with a prescription and now they're calling us a month later in pain again, at that point, we were open to scheduling an appointment. And if they kind of kept refusing to come in, then that might be a little bit of a red flag for us. So at that point, you would say, I'm sorry, like I'm unable to treat you anymore over the phone or over video. We're really going to have to get you in the office. And we had some patients that maybe didn't have transportation. So that's why they were saying they couldn't come in. And I certainly, wanted to believe it. So we tried to eliminate that barrier for them. Is there a way that we can bring them into the office? So, well, there weren't set guidelines. I wasn't prescribing opioids over telehealth, especially because a lot of the patients that were calling then I might not have ever met in person. So I didn't really know the background with them. And we were just making space for patients that were in so much pain. We were telling them we're going to find a way to take care of you. So I think that that's one way to kind of weed those patients out.
That's great advice. I was looking at the April issue of the PA Dental Journal, and there's an article discussing the Costello guidelines for addressing pain medications. Are you familiar with that article?
Yeah, so I actually, I'm a member of the PDA, so I did read the article. I got the journal.
What are your thoughts on that? Could you just give us a little explanation for our listeners? Just summarize what your thoughts on that article and those guidelines are for dentistry?
Yeah, so before I read the article, I actually had never heard of the guidelines before. Um, so the Costello guidelines, they were created by Dr. Costello, who's the dean of Pitt's Dental School. And since I was at Temple, that's probably why I wasn't familiar with them before that. But really, the main idea was to manage pain with non-opioid meds whenever possible, because typically they do work better for dental pain, and they also don't have the same negative side effects that opioids might have, and the potential for misuse and for addiction. Um, they note that providers also really should consider what dental procedure is being performed, and the severity, the duration, as well as the unique risks that each patient might have when we prescribe them medications. So really each situation is unique. So at times there could be exceptions to the guidelines, but um, they really said how, those typically would be rare. So the Costello guidelines, they really changed the trend of opioid prescriptions, so that they don't start at such a young age, because in these guidelines, they don't make any space for what you might call just in case opioids. And I think what makes these guidelines unique compared to some other guidelines is that they really provide some clear standardization. The way that they've written it up, it's clear what patients can expect from every provider who's following the guidelines, or what they call their Costello pledge. Um, and every provider really would be following those, except for the very rare circumstances. Um, so first, the way they have it set up, you determine if a patient can tolerate ibuprofen and or acetaminophen, and then you determine the expected level of their post-op pain, whether that's mild, moderate, or severe. And they even list what specific dental procedures might fall into those different categories. So it takes out a lot of that guesswork, and therefore it takes out your tendency to give something just in case. Um, and I think this is really helpful because teenagers, they're not going to get opioids after a wisdom tooth extraction just in case. And even patients undergoing other procedures, since they can be managed just fine most of the time with non opioids, they won't have just in case medications that can sit in a medicine cabinet for somebody to then access later, who might be young and potentially lead them into a cycle of addiction. So I was really interested in these guidelines and hope to implement these into my practice.
That's great. I see the only downside of the non-opioid after tooth extraction is we would lose all those funny TikTok videos that we see, people coming off of their anesthesia.
That's true.
So anyway, moving on. I know myself, I learn much more from experience or through a real life example. So in your practice, could you run us through a case scenario that would highlight some of the impact of the opioid epidemic and how that has affected the population you serve?
Yeah, so I think it's hard to pick just one. Um, we see so many patients who are either in active addiction or in recovery, but one particular patient that really comes to mind is somebody that's actually my age. And I know you can't see me, but I promise you that I'm young. So it was a bit of a shock to me that, she was in our medication assisted treatment program. Her teeth were all broken down to severe decay. And she never smiled. And she told me how she was too embarrassed to, and she was embarrassed that her kids would see her without teeth. Um, so when I made her treatment plan, I really didn't have to do a lot of convincing with her that we were going to extract all of her teeth and make her complete dentures. But she did have one really big concern, and that was how painful the extractions were going to be. In looking at her teeth clinically and looking at the x-rays, they were pretty straightforward extractions. And for me, they would be pretty simple. But I didn't want to forget about her concern, which was what the pain is going to be like afterwards. And for her, she was afraid that she might be tempted to use opioids, and kind of set her back into her addiction. So what I did, for her, I started with only 2 extractions. So that way she was able to see what the procedure was like. And, if she did have post-op pain um, that was moderate or more severe, that was something that we could manage together rather than doing all the extractions at one time. But it went really well. And, in future visits, I was able to complete many more extractions for her at one time. Um, so I think I was able to treat her and really manage her pain with non-opioid meds. But even more important than that, I was able to establish her trust. I think there's often a stigma around patients either in addiction or in recovery. And it was just important for me to show her that I was there to help her and I understood her concerns, and I was going to make sure she was comfortable every step of the way. So if she had that moderate or severe pain afterwards, we'd be able to handle that with something that wasn't an opioid. Um, And after she healed, I was able to make her complete dentures. And it was really great to see her finally smiling and see her, her whole personality shine through. And I think for her, it was really a way to start fresh and kind of wipe away one of the signs of the difficult time in her life, because obviously during her addiction, that had really taken a toll on her mouth. And um, really, then ultimately, it was still affecting her personality, even when she was in recovery, just because she felt like she couldn't be her whole self um, while she was still trying to, hide her teeth. Um, so I think that's one example of something that we see kind of frequently, that ends up, it ends up being a good success story, which is nice. Not every visit is one of the difficult ones, like I mentioned earlier. There are definitely the happy visits too.
Yeah, that's great how you could walk her through that. And I'm sure that was a major relief for her, just knowing that she could have something like that done without worrying about getting back on opioids and restarting that whole vicious cycle again. So that's a great example. Thank you. Um, and also, based on your experience, I know you said you had a lot of examples, and that was just one of them. But from those examples, are you able to draw any like pearls of wisdom, things that you could share with our listeners that they might be able to take home with them and apply to their practice? Or maybe if they come across a specific patient that they're like, I remember talked about this on our podcast.
Yeah, so I think it's really important not to assume that everybody asking for an opioid is an addict. Um, you might hear people say, oh, they're a doctor shopper, and you just want to get them out of your chair. But I think we really need to avoid kind of saying that and think about like why they're in your chair and why are they asking for this. A lot of patients, they might just be asking for what they might consider a stronger prescription, because they're worried about the pain, and certainly nobody likes pain. um, so they don't always know that there are some milder medications or treatments that can help to address their pain, and might even work better than what they're thinking. um, so as a provider, I think you not only have the opportunity but also the responsibility really to educate them. um, and there definitely might be a history of mistrust based on past experiences that they've had, whether in their personal lives or with other providers, especially if they're kind of being shooed out of an office. So I think it's really good to sit and talk to them. And the best way that I find to move forward is to really connect with the patient and find a mutual goal. So in this instance, the goal, both you and the patient, you really have the goal of getting the patient out of pain. Um, but you maybe have some different ideas of how you'd like to get there. So you can help the patient to understand that you really share their same goal and you want to get there together, but you might have ideas for a safer way to help them be pain free. And, hopefully that's something that they'll be receptive to, once you've established that initial trust with them.
Wow, that's great. Well, that about wraps it up then, I think. So thank you, Dr. Burkhardt. It was really great talking with you today. I hope that our listeners found your information helpful and that they can take some of that back to their practice and apply it to the way that they deal with patients who might have an opioid use disorder. And hopefully this makes at least a small dent on the whole opioid crisis across the state and across the country for that matter. So with that, I will pass it back to Jill to wrap it up for us there.
Thank you both for having me.
Thank you.
Thank you, Dr. Burkhardt, for joining us today, and Jason, and sharing these great perspectives with us. The education team at Quality Insights is readily available to answer any questions you may have related to the topics discussed today. If you'd like to get in touch with us, please send us an email at pdmpeducation@qualityinsights.org. Or feel free to visit our website as well. As I mentioned at the start of today's show, Quality Insights, in partnership with the Pennsylvania Department of Health, offers a presentation tailored specifically to the dental community called Opioid Prescribing and Dentistry. We invite you to contact us directly if you'd like to talk about ways we can offer this presentation in your dental care setting. You could even have Dr. Burkhardt join you as well. We want to go ahead and thank you for your dedication to providing quality care to the patients you serve. We look forward to seeing you in an upcoming presentation or podcast.